Good evening, sir. Can you hear me?
Yes, I can hear you.
Yes, sir. Sir, Dr. Lakshmi had actually called around 7:30. She got called for an emergency perforation, it seems. So she said she'll try to finish the case early and join by 9, or she'll join as we go on with the case presentation,
Not
sir.
a problem. Not a problem.
Thank you, sir. A very good evening to all here, and thank you for joining us for the second of our case presentation series. So today we have Dr. Priyanka, who's a final year MCH pediatric surgery resident from BJMC Ahmedabad. And our examiners for today is Professor Yogesh Saran, HOD of Lady Harding in Delhi, and Professor Lakshmi from KKCTH in Chennai. Both are very eminent and very senior professors as well as examiners. So I look forward to all of us learning from them today. So I think, Priyanka, you can start.
Okay. Good evening, everyone. I am here to present a case on a right flank mass. Informant being a mother, a 3-year-old female patient presented to us with complaint of abdominal lump for 1 month and bloody urine since 3 days observed by mother. Patient was relatively asymptomatic before 1 month. Then mother incidentally noticed over the right side of the abdomen, which was slowly increasing in size for last 1 month. Sudden increase in size was noted in last 2 days. Bloody urine was observed by mother in last 3 days, which was sudden in onset, painless, and seen throughout the urination. Patient came to us by after treating some primary treatment. There is no history of trauma or acute illness recently, no history of pain associated with swelling, no history of crying during maturation or pyuria, no history of sudden increase in size of lump or sudden decrease in size after the maturation, no history of easy bruising or unexplained bleeding, no history of chronic cough, respiratory distress, hemoptysis or pain in chest, no history of jaundice or any lower limb swelling. No history of any abnormal bony swellings or difficulty in walking. No history of dizziness, blurring of vision, or any headaches. There is no fever, vomiting, loss of weight, or loss of appetite. There is no excessive sweating, flushing, loose motions, abnormal eye movements, or abnormal body posturings. No history of other swellings in the abdomen and groin. No history of any abnormal looking genitalia as noticed by mother. No history of asymmetric limb growth or the bowel bladder habits were normal. There is no history of significant illness or hospitalization in past. Patient is tolerating food very well. Normal bowel bladder habits are noted. Normal antenatal scan in mother, and there is a history of preeclampsia during pregnancy. So patient is full term LSCS born, cried soon after birth, immunized for age, and developmental milestones are achieved. No history of any malignancy or renal diseases in family. Patient is, should I put examination?
Yeah, so from the history, can you just summarize it and tell me can you tell me what are the differential diagnoses
From
coming to your mind? Because whenever you then from
from
there
this
you can may I finish? From there you kind of have an idea what to look for or look against when you do examination.
Yes, sir. As my patient primarily presented at the 3 years of age with abdominal lump and hematuria. So I would like to keep my first diagnosis as renal origin tumor. Most probably the Wilms tumor will be my first diagnosis. Other diagnosis could be neuroblastoma or any retroperitoneal mass, tumor, teratoma can be there.
So, how would you explain hematuria if you're thinking of neuroblastoma or teratoma?
Sir, it will be very rare, but in neuroblastoma, if the tumor is very large and compressing the renal vein, and it will cause renal vein thrombosis or compressing the renal parenchyma, then it could be possible that patient will have hematuria.
The only diagnosis could be when there is a intrarenal neuroblastoma. Otherwise, the kind of mechanism that you're suggesting to have a neuroblastoma doing hematuria, I've never heard of, So similarly, it will go. Now, the point I was trying to come to is that at times the history is very, very obvious.
Yes, sir.
So most of the residents feel that if they would come out with just one diagnosis, they will be probably rejected or they'll not be accepted. But that's not really not the case. Sometimes there's picture book picture kind of presentation
Yes,
that
sir.
happens. From there, you can actually pick up a diagnosis. Say, at this moment, I do not think I have any other differential diagnosis. That's perfectly acceptable, at least to me.
Yes, sir.
So, if you have thought of Wilms tumor, what percentage of them are syndromic, really?
Wilms tumor syndromic patients will be 10 to 20%, sir. And if we separate the other syndromes, like if Weger syndrome, Wilms, aniridia, genitourinary and mental retardation, it would be 30 to 40%. And if there is associated Dennis Rush, then it will be 70%. And if Beckwith-Widman syndrome, there will be 7% chance of getting the Wilms tumor, sir.
No, those things that you're saying is right. But two observations. One, the incidence of syndromic Wilms tumor that you mentioned, that's high. I mean, you said 10 to 20. That's not the truth. It's lesser. Secondly, we don't use the word mental retardation anymore when we talk about Vaga.
Yes, sir.
Mental retardation is one term now, which is not kind of liked, the word that is used instead. So in their history, have you kind of ruled out all those by asking any questions really?
Yes, sir. How is the for other syndromic association? I would ask mother about the any asymmetrical hypertrophy of limb, any abnormal looking genitalia, any swelling in the inguinal or groin region is present, or patient is playing with other kids and mother and having normal behavior and intellectual with other social and mother. Then I would rule out other syndromic association. Any other macroglossia or umbilical swelling, omphalocele in the neonatal age, then it will rule out the Beckwith-Whitman syndrome. Any other any other swelling in the abdomen or any other tumor like embryonal origin, other tumors would be also associated with the Beckwith-Whitman syndrome. I would rule out like that, sir.
Okay, go on to your examination.
I have examined my patient room with proper exposure. My patient is conscious, active and playful, well hydrated and well nourished, normal facial appearances with symmetrical growth, paler teres, cyanosis, pedal edema or generalized lymphadenopathy. Pulse rate is 110 per minute in right radial artery and BP is 136 by 100, which is more than 95th percentile for this age, which I have measured when patient is calm sitting with the mother on the right arm. With appropriate cuff size. Height is 115 centimeter and weight is 15 kg, which is normal for her age group. Coming to the systemic examination, on laboratory finding, patient is having protuberant abdomen with centrally placed umbilicus. There is an abdominal mass in the right side of the flank involving the right hypochondriac, right lumbar and umbilical region. So it's globular in shape on vision. And right-sided renal angle fullness can be seen. There is no scar, pigmentation or engorged vein. There is any other visible swelling. visible peristalsis or pulsatile movements. External genitals appear normal, back and spine visibly normal. On palpation, there is a single euthermic non-tender immobile 11 cross 10 centimeter mass occupying the right lumbar, right hypochondriac and umbilical region with smooth surface, firm in consistency and well-defined margins, reaching just up the midline. Mass is bimanually angulous, not tender. Mass is moving up and down with the respiration. Fingers can be insinuated slightly between the mass and the costal margin. Liver margin is just palpable beyond the costal margin. Mass is dull on percussion without any appreciable band of colonic resonance in this patient. Dullness over the mass is not continuous with the liver dullness. Right-sided loin lateral to the erector spinae, dull note is present, and there is no shifting dullness or sign of any free fluid in the abdomen. Liver span is 14 centimeter. There is no abnormal sounds or bruit heard on the abdomen. Respiratory and cardiovascular examination is normal. So,
Go on.
yes. I would like to summarize this case on my history and examination finding. Like 3-year-old female non-syndromic child presented with hematuria and right-sided abdominal lump, which is solitary, firm, non-tender in the right side flank without any evidence of metastasis, most probably neoplasm of renal origin, Wilms tumor.
Did you rule out hemihypertrophy on this patient on
Yes.
examination as well?
Yes, sir. In general examination, I have mentioned that patient not having any asymmetrical growth of or hypertrophy of limb.
How
What
did you,
about the, okay, it's a female child.
how did you do it?
Sir. In some syndromes like Fraser syndrome,
Don't tell me all
there
that.
is
No, don't tell me all that. We'll talk about that. How did you rule out a hemihypertrophy on physical examination?
Sir, I will look on inspectory finding that there is a one limb is hypertrophied or not, and I would measure also on a thigh and mid arm for the girth and compare it with the another limb.
So how do you, I mean, I know a lot of people do not kind of ask these details, but I realize I'm an old timer, maybe, you know. How do you do mid-arm and mid-thigh circumference? What are the bony points that we're talking about?
Mid-arm circumference should be measured from the shoulder acromion point and from the elbow olecranon process. Between that there will be the mid circumference, sir.
Yeah, so your diagnosis is just the renal neoplasm and nothing else. Do you have
Yes, sir.
any differential diagnosis uh, of a renal lump or renal mass as of now?
No, sir, I would like to define it as a Wilms tumor only. Right now, I am thinking about Wilms tumor only. But it can be other tumor like clear cell sarcoma, but it would more present with bony abnormalities, difficulty in walking, or bone metastatic features would be more, or brain metastasis. It would not present for this age group. My most probable diagnosis will be Wilms tumor only, sir.
No, please try to understand. I agree that there are different age groups for different non-Wilms renal tumors.
Yes, sir.
But not every new non-Wilms renal tumor would have a brain metastasis, etc., etc. We know that a certain non-Wilms renal tumor would have a higher incidence. So you can't. And on physical examination or history, you may not be able to pick up a brain metastasis if it is supposed to be.
Yes.
Besides that, I mean, you just focused on a malignancy of the kidney. Why not some benign condition of a kidney?
Sir, as this patient, there is no history of any pyuria, fever, or any history of UTI, then I would, and patient presented with hematuria also. So I would like to rule out other inflammatory causes, traumatic causes.
A patient having hydronephrosis due to PUGO after trivial trauma, which she may not remember, could have hematuria.
Yes, sir. But this patient is also having hypertension and the on palpation.
PUGO hydronephrosis patients may have hypertension. You know, what happens is it works both ways. If you're very sure about your diagnosis and all that, and you say only single diagnosis, I'm okay with that. But you have to just then justify why you're saying that. At the same time, it's not okay that you make up your mind and say it's just renal tumor and nothing else. I mean, that also doesn't work with me. So you have to then justify why it could not have a differential diagnosis of this being a benign lesion of whatever origin.
As
Can
patient
I
is
say a
doing
few
well,
words
and
here?
when it scan. Sorry,
Yeah,
sir.
let's
Sorry,
go
ma'am.
on.
Yeah. Sorry, Priyanka, I was operating, so I might have missed some of your presentation.
You were
But
there
did
before you.
no, no, I was there, but I might have missed some of the words. But did you mention painless hematuria? Did you use the word painless hematuria?
Yes.
Have you
Yes, ma'am.
described the hematuria in terms of how severe it was and how many episodes and how red the urine was, or is it getting better, getting worse? Have you described the hematuria in greater detail? I might have missed it, so I'm just asking.
Uh, yes, ma'am. No,
that
ma'am. I
that
have
clots
just
in the
mentioned
urine,
it.
what is it? Yeah, I think those details are important. So whether
Yes,
you
ma'am.
are having clots in the urine, whether it is intermittent hematuria, whether the hematuria is
Yes.
cleared now, or is it just rosé? So those kind of
Yes.
details are quite important when you're talking about that. And I specifically think that word painless hematuria is very important,
Yes,
because
ma'am.
a
I have
painful
mentioned.
hematuria could mean something completely different, right?
Yes. Yes.
And from your presentation, you got, a fairly, what looks like a fairly straightforward case with, a smooth, is it a bosselated swelling or is it a smooth swelling?
No, ma'am. It is a smooth smell swelling.
Smooth swelling. And it's already palpable in the abdominal wall, right? So is it bimanually palpable? Are you able to feel it from both sides?
Yes, ma'am.
Can
It
you
is
tell us how
bimanually
you would
palpable.
look for bimanual palpation? How will you actually do
I
that?
will Patient will be in the sitting position. I will stand by the side of the patient and keep my hand on the back, and I would palpate it from the side and from the front. One hand on the right side flank on the ventral aspect, and other hand on the back. And then I would push from the front and palpate it on the back. Push from the back and palpate it on the front. So it will be
Priyanka,
palpable.
that is called ballotability.
Sorry. Yes,
Okay,
bimanually
so that's
palpable.
not
It is.
bimanual palpability.
Yes.
And
Yes.
secondly, although the child 3 years old, and you twice have mentioned already that you will be doing it sitting,
Sitting position.
preferably
Yes.
the child should be lying down when you do all this
Lying down.
examination, if
Okay.
especially if
Yeah.
mom is there.
Okay.
Huh?
So I think it's important to understand what the basic terms that we use mean. What is bimanual palpation? So what we are
When
trying to do in bimanual palpation, you're not pushing the lump from front
yes,
to
yes.
back
Okay.
or back to front or anything. You are just palpating from front and
Palpating with the
palpating
both.
from back. And you are
Yeah.
able to feel the same swelling from both the palpating hands at the
Yes, yes,
same time. Then
yes.
that's bimanual palpation. It is done in the lying down, supine lying down position, right?
Okay.
And ballotability comes when the swelling is already not palpable from both sides.
Primary palpation.
If by
Yes,
touching the patient, it is palpable without any pressure. Without
yes,
any pressure, the swelling is already palpable from the front and the back.
yes,
Then
ma'am.
you can't really do ballotability.
Yes, ma'am.
Ballotability is for a swelling that is smaller, so that
Small
when
size.
you're just keeping your hand on the abdominal wall, the swelling is not directly palpable, right?
Yes, yes,
In that situation, you put your hands behind, push it,
yes, ma'am.
and like like a ball, you are able to bounce it off, and it comes and hits your anterior hand.
Yes, ma'am.
So that is what ballotable is. Okay, so you
Yes,
should
ma'am.
know the difference between those
Yes,
two
ma'am.
and how to
Yes, ma'am.
examine. And we don't examine children in the sitting position at all.
Yes, ma'am.
There's
Yes,
no
ma'am.
question of examining this child in the sitting position. All right.
Yes.
Is the
Yes.
contralateral kidney palpable? Did you mention that? I wasn't very clear. I
No,
wasn't
ma'am.
sure.
Contralateral kidney is not palpable, ma'am.
And liver is also not palpable.
Liver just palpable, just below the costal margin.
And other thing I expect in when you're talking about these kind of flank masses is I would like you to say that it is a well-looking child, well-nourished child,
Yes,
well-looking child, not a sick-looking child.
yes,
Right?
ma'am.
Now, why is that important? Why is that important?
Ma'am, in neuroblastoma, the patient would be sick looking, ill looking, or any other malignant tumor, there will be more ill looking child. But in Wilms tumor, patient will be well nourished. In
Right.
hepatoblastoma, neuroblastoma.
What other renal conditions will give you a palpable kidney? Right. What other renal conditions
Yes.
will give you a palpable kidney? This is what
In
Dr. Sareen was also asking for.
yes,
Why you are saying
benign.
only will? So, what other conditions of the kidney will give you a palpable lump?
In benign conditions, there will be pelvic ureteric junction obstruction, PUGO, or it can be pyonephrosis or xanthogranulomatous pyonephritis. In benign tumors would be like, not for this age group, but cystic nephroma, cystic partially differentiated nephroblastoma, or mesoblastic nephroblastoma would be palpable. Rhabdoid tumor of kidney, clear cell sarcoma of clear cell sarcoma of the kidney, or teratoma of the kidney are the palpable tumors which are malignant, like Wilms tumor.
Can it be a non-renal mass?
Uh, yes. Sorry,
You said there is
non-renal.
no band of resonance over it. There is no band of resonance over it. You've just got a swelling in the
Yes.
left flank.
Yes, yes.
So, I mean, why do you say it's a kidney, first of all? That's my question.
As patient presented with hematuria also, then
Okay. So that hematuria is the reason you're saying that. Suppose this patient didn't have hematuria. What else can be there in your DD?
neuroblastoma can be there for my DD. But as this patient is well preserved and well nourished, and age group is 3 years and not a common age group of neuroblastoma, then I would keep it at a later differential.
So,
Not
Priyanka,
What other?
what
Go on, please.
he's trying to hint is, uh, see, neuroplasma not there. No, you know it. I know it because the patient is not sick looking. Patient, we all know that. No, you said smooth mass, this, that. But what Lakshmi is, Lakshmi, can I address you, Lakshmi? I always address
Yes,
people by first
please.
name.
Yeah, please.
Yeah. So, what she's asking is, could you have a well-defined globular smooth mass in that region, as you described, of that size, 11 into 10
yes.
centimeter, which is of no renal origin, non-renal origin?
Yes, ovarian tumor could be present.
Ah, now you're talking. So it's a girl, huh?
Yes, yes.
Okay, what else? What else?
Ovarian tumor.
Teratoma, rhabdomyosarcoma.
No,
Sorry.
Priyanka, you're talking very wild here as of now. Okay, I'm sorry. I am one of the difficult guys in the exam here. I mean, people don't like me to be examiners really most of the time. Yeah, so you're talking very wild. I mean, you're talking about a tumor which is higher up, which is not coming from the lower abdomen. We're talking, we can't just throw any ring into, you need to be, we're talking
No,
about
what else? What else I'm
upper
just saying?
abdominal
If you're
right
talking.
side mass here.
Liver, mass could also be originating from the liver or retroperitoneum. It could be retroperitoneal
Ah,
teratoma, or it can be liver tumor like hamartoma. But this is not the age group of any hepatoblastoma or any other common liver tumor. So I would keep it as a later diagnostic. And there could
Could be
also
a
not
choledochal cyst. Okay,
choledochal cyst.
I'm throwing
Yes,
something to you.
yes,
Could it
yes.
be a choledochal cyst?
Yes, sir. It could be colorectal cyst, but there is no history of generalized weakness or jaundice or any fever or any episode of cholangitis, as patient has become 3 years of age. So, and the mass is not continuous
The,
with the
the,
liver
the
also.
typical triad in a choledochal cyst is hardly seen in about 10% of
Yes,
cases.
yes, sir.
Okay? So, see, I repeat my words. There can be tumors which are very classical, and you can say, oh, this is Wilms tumor. And if you don't give me a differential diagnosis, I'm perfectly okay with it. Yeah.
Yes, sir.
Yours with hematuria and with hypertension, I would buy even that. Yeah. But here Lakshmi says, suppose the hypertension wasn't there, suppose hematuria wasn't there, then could you throw in some differential diagnosis? Now, if
Yes, sir.
you would throw in differential diagnosis like, neuroblastoma, this, that is not acceptable because you have to keep the other things in place, like the tumor is smooth, well defined, all
Yes, sir.
that. So for that, you need to then think of all kind of things, congenital abnormalities. You can have to think of infective pathologies,
Yes.
etc., which would throw up a mass in the right upper abdomen. You can't just jump and tell me about ovary then, right? Okay.
Okay. Yes, sir.
So what I'm trying to say is that uh, every case is different, and we are talking about this case. And here, one of the examiners has told you, okay, no hematuria, no hypertension, and do you think such a situation if it's there, what could you be one, two, three, four, five diagnoses? And they have to be specific. They can't be just very, very vague there.
Okay, sir. Choledochal cyst could be there, but on my palpation finding, the mass is not continuity with the liver or not moving with respiration that good, and patient there is no history suggestive of any jaundice or weakness or so I would like to keep it as a not hepatobiliary or
And it's a
the
firm mass, isn't it? It's
firm
the
mass.
firm
Yes.
mass. Firm mass with well-defined edges.
Defined, yes.
Firm mass with well-defined edges, which is less likely to be that. So can it be a gastric teratoma?
Yes, ma'am. It can be gastric teratoma, but then if for this huge mass, if there is a gastric teratoma, then patient should be presented with symptoms of gastric outlet obstruction, ma'am. And there should be vomiting
Not
or
necessarily.
loss
If
of
it's a
appetite.
body of the mass, body of the stomach, there won't be features of gastric outlet obstruction. Okay.
Hematemesis or pain in abdomen can be the fullness, postprandial fullness would be there.
So can it be a pancreatic tumor?
Pancreatic tumor would be more of a epigastric mass, ma'am. And it will, if there is a in the right side, then it would be compressing the duodenum or the CBD. It could cause jaundice
Yeah, but this is
and it
left
could cause
side. Huh?
gastric
This is
outlet obstruction
left side.
also.
This is
Yes.
left side.
Mm.
So why are you talking about if it is on the right? It is a left side.
Oh,
No, no, right side.
Yeah.
This is right.
my case
Oh,
is
this is
right.
a right mass, is it?
Yes.
Yeah.
Oh, it's a right-sided mass. Okay. Okay. All right. Yeah. Okay.
Uh, uh, So we could have
Shall we
see
move on?
a large cyst, whether it's choledochal cyst, a giant choledochal cyst could also feel like that. A very giant hydronephrosis could feel like that.
Yes.
They also have that firm feeling, and they could be so one. And secondly, no, a large choledochal cyst also may not be very appreciable to
No,
move
one
the
second.
respiration
Please, I'm
line.
presenting. No, no, I'm presenting.
Can others please mute themselves?
So you should have a very large view of the things, but sure, when it is hematuria, hypertension, etc., I would be even happy if you would say it could be a renal origin, Wilms tumor, or any non-Wilms renal tumor, or maybe even hydronephrosis because PUGO, because the trivial trauma can still cause hematuria
Yes.
in the presentation like that. So let's go on from there. And now, how would you diagnose and finalize your diagnosis?
Sir, I would like to do abdominal X-ray, chest X-ray, ultrasound for this patient first. And in ultrasound, I would like to
No,
see
you
the,
said you'll do abdominal X-ray first.
yes,
Nothing comes for free in the market as of today. If you have to do abdominal X-ray, you'll explain to me why would you do an abdominal X-ray?
sir, abdominal X-ray, not give that much information, but we can say for the calcification, there is a axial calcification in some Wilms tumor, and there is a gross punctate calcification seen in neuroblastoma or teratoma, and it
So
will not give that
what
much.
is the
Priyanka, is there some information you will get from X-ray which you cannot get from more relevant investigations? That is a question. If you're going to do an ultrasound, will that not show the calcification anyway?
Yes, sir.
Is there any use, any additional use of specifically asking for an X-ray abdomen? Do you do normally an X-ray in your hospital
Yes.
for suspected Wilms tumors? You do, is it? Okay. So
why?
you see, we don't
No,
do.
no.
We
Why?
don't do. So that
Why?
Any bony abnormalities can also be seen.
Okay.
If there's any metastasis,
Like, no. Just go very slow. For Wilms tumor, I've got 84 present publications. Okay, I've worked on every aspect of Wilms tumor, by the way, right?
Yes.
So if you would say calcification of Wilms tumor, there is a paper on calcification. Then what all calcification, what type of calcification I can go, and then I'll ask you Ramses tetrad, then I'll ask you, let's not get so. If you say your institution, by the way, Rakesh is a very good friend, okay, and so is Jeshri. If you say the calcification, that's why whatever, I won't buy it. I just won't buy it. Okay, I'm a hard negotiator. I would not buy it, right? When you say chest X-ray, sure, we listen. But first, we need to know. We were talking about 510 kind of differential diagnosis. We need to know what is the origin of this swelling. So,
Yes.
what would you do?
I would first do my first investigation of choice would be ultrasound, sir.
okay. Okay.
So,
In
What are you
ultrasound,
what are you looking for? What is that ultrasound done for?
in ultrasound, I would look for the organ of origin. If from the kidney, it is cystic or solid, the size, the parenchyma is preserved or not. Is there any hydronephrosis? I would look for the ureter also, contralateral kidney, peritoneum, lymph nodes, and in real-time image, if there is any liver involvement or not, or it is any other adjacent organs are involved or not. Is there any by Doppler? I would like to see for the renal vein or IVC thrombosis is present or not.
you said cystic or solid. Why can't it be cystic and solid?
Yes, sir. It can be both. Cystic solid, yes, sir.
Right. So, did you do an ultrasound for this patient?
And
Sir, yes.
calcification, sorry, and calcification also on
Yes, sir. Yes, sir.
ultrasound.
Yes, sir. Yes, sir.
Yeah.
What kind of calcification do you have? What is classical for Wilms tumor, and why does it
Eggshell,
happen?
eggshell calcification,
Why does
sir.
it happen?
Sir, due to compression and splaying of the renal parenchyma at the one side, there will
No. It happens because the subcapsular hemorrhage that has happened.
subcapsular hemorrhage and then calcification would be there. Yes, sir.
Yeah,
And it will be compressed by normal parenchyma and capsule, so it would look like eggshell, eccentric.
So what
because
does an ultrasound give you that a CT or something else, some other investigation will not give you? What is ultrasound specifically good at?
Real-time imaging, adjacent organs are involved or not, liver.
No. Can you treat this patient with only an ultrasound?
No, ma'am, I would like to do
No.
CT scan also.
So you have to do what CT?
Contrast CT, abdomen, pelvis, and non-contrast chest.
So if you are anyway going to do a CT, what extra information would you have got by doing the ultrasound? That is my question.
Contralateral kidney is involved
In
or
what
not?
way is ultrasound better than a CECT? In what way is an ultrasound better than a CECT? In certain specific ways, ultrasound is better. So what is it better at?
Contralateral is involved or not? Ureter is involved.
Sorry? I didn't get you. What is it?
Ma'am, contralateral kidney is involved. Am I audible?
No. Yeah.
Internet
Yeah. No, those things are only on CT. CT is only good for contralateral kidney. So I think Evangeline has already said, basically to look at the renal vein and IVC, the Doppler.
Doppler, yes.
For
Yes.
that alone, the ultrasound is even better than CECT for that. Huh?
Priyanka, you just mentioned something which I must clarify, and This was others also attending. You said CCT for abdomen pelvis and non-CT for. It's not like that. Okay. If you are doing CCT, then it is CCT abdomen
Human
chest and
pelvis
neck,
for
right?
X. Yes,
Now
yes.
the thing is that what new investigation that has come?
MRI. Yes, sir.
MRI. So
Then we
both,
do the non-contrast CT, sir. Yes, sir.
yeah, if you're doing MRI, then you would do a non-contrast
Contrast.
CT of the chest.
Just before the
And
MRI.
which one of the two investigations then you do first?
CT, non-contrast CT, I would do first.
Why?
Because MRI, we give sedation and anesthesia that would cause atelectasis or
Very good, very good, very good. Yeah, go on now. So you done a ultrasound. Do you have findings of that? Would you share it with us?
yes, this patient came with ultrasound outside. The ultrasound was done outside, and then patient was referred to us. This is the ultrasound finding. I have only the report, not the recording. There is a large, well-defined, mixed echogenic, predominantly hypoechoic solid cystic lesion, 12 by 9 centimeter in the right renal fossa. Right kidney not appeared separately from the lesion, and there is it extends up to inferior surface of the liver, and infrahepatic subhepatic portion of IVC is visualized, appears normal. Renal vein is not visualized. There is a large malignant mass in the right side renal fossa, suggestive of Wilms tumor, sir.
All right. Now explain to me why does the Wilms tumor, unlike neuroblastoma, do not go the opposite side? Sure, very large Wilms tumor overhang and some bit is palpable beyond the midline. But they are not like neuroblastoma, which is actually present from one side to the other flank. What kind of holds it back to be there so that it kind of stays till the midline?
Sir, capsule,
Right.
renal capsule, gerotas.
हाँ बेटा बट कैप्सूल और जेरोटस को एक साथ नहीं बोल सकते हैं
Yes.
तुम लोग तुम्हारी प्रॉब्लम पता है क्या है तुमको आता सब कुछ है बट बहुत कैजुअली बोलती हो तुम you don't need to be casual in the exam. I am one very particular man, please. So don't just say anything casually. Girotas fascia. So the next
Gerotas
question
patient.
should
Yes.
always be asked if you are talking about renal, what are the attachments of Girotas fascia? Above, below, laterally, and medially? I'm an old timer, right? No, I just don't say MIS and switch over my screen. No, it doesn't happen like that with me, at least.
Yes.
Do you know or do you don't know?
Not no, surely, sir. Posteriorly, there will be
No
psoas.
problems, no problems. So you did a Wilms and you come to know it's a Wilms tumor. Then what else did you do?
Sir, I did a CCT abdomen pelvis thorax, sir.
You did not do a CBC?
Yes, sir. In laboratory investigation, I did a, complete blood workup, serum electrolyte, normal renal function test, PT,
Why
APT.
would you bother about electrolytes? I mean, I wouldn't be.
Sir,
I would be
sometimes,
bothered about
yes,
certain specific things
yes, sir.
which are
I
not
would.
mentioned on the screen.
Yes, sir. Electrolytes I have done because this patient has hypertension also. So due to renin, there is hyperaldosteronism which cause hypokalemia sometimes. To rule out any electrolyte abnormality or any renal function deterioration due to syndromic glomerulopathies, that can be serum electrolyte imbalance. Just to rule out that, I have done it baseline investigation, and
In the counts, something which is specific of worms, not seen in India
yes,
often.
sir. Sir, prolonged bleeding time, von Willebrand factor, acquired von Willebrand deficiency due to autoantibodies or tumor surface would attract the von Willebrand factor, and it will be less. So there will be the acquired von Willebrand syndrome.
Yeah. Right. Go on. CT scan.
So why is the platelet count 81,000 in this child? Is that
Ma'am,
right?
patient, when we first admitted the patient, the anemia was also there. Hemoglobin was 8 and platelet was also 81,000 and patient was with hematuria and but not passing any clots. But after 1 or 2 days, the platelet count has also improved to 2 lakhs and hemoglobin after 1 PCV, there will be 10. That will be 10, sir, ma'am.
Okay. Okay. So why is creatinine important?
Ma'am, the residual renal parenchyma is functioning with contralateral kidney. If there is bilateral Wilms tumor or any syndromic patient which is having glomerulopathy, there will be the creatinine would be high in such cases.
Is that the only reason you're doing it? Why are you doing the creatinine?
For CECT abdomen pelvis also it is necessary,
For giving
and for
contrast. For
preoperative
giving
fit,
contrast.
yes,
For
contrast.
giving contrast. You
Yes,
need
yes,
that. No,
contrast.
first of all,
Yes,
you need that. Yeah. Okay.
yes, yes.
Okay. Can we see the CECT because we don't have much time?
This is the
Yeah.
CECT abdomen pelvis. Some shots I have taken. Here I can see there is a right-sided kidney from almost upper and middle pole is covering
Pinky?
with the
Pinky?
solid. Sorry. Solid cystic tumor with laterally I can see some hyperintense foci, which is probably due to hemorrhage. And there is a splaying of renal parenchyma can be seen. From the adjacent organs, I can see a plane with a preserved fat plane. In this image, I cannot see the IVC, but in the proper CT plates, there was no echo. No hypoattenuated foci on the IVC is visible. It is just up to the midline, just cross, no, not crossing it, but just up to the midline. Here I can see. And there
So
is
the
a
report is
pseudocapsule
there is
seen.
no thrombus, is it? No renal
No,
vein or IVC thrombus they are saying on this?
no. In a CT scan, they are saying there is renal vein is not visible clearly, but IVC there is no thrombus.
Okay, go ahead. How would you manage this patient?
Sorry, one more thing. Are they able to see any nodes? Have they said anything about nodes?
No enlarged para-aortic or paracaval nodes are visible in this patient. No significant lymphadenopathy was seen.
Liver?
Liver was also normal. Chest, there is no nodules. In chest plates,
Okay.
there was no nodules. In
Okay.
contralateral kidney, there is no hydronephrosis and it is normal also.
How would you manage this patient?
Sir, we follow the COG and National Wilms Tumor protocol. So I would like to do
No, there is no National Wilms tumor protocol as a.
COG protocol. We follow the
When
COG
did we
protocol.
move from NWTS to COG?
Sorry, sir.
In 2001,
Yes, sir.
right? So since
Umbrella
then,
protocol.
we will
Yes.
talk about only COG.
Yes, yes, sir. Yes, sir.
All right, then what do?
I would go for after stabilization. I would like to go for a upfront surgery after the hypertension is medically stable. Then I would like to go for a upfront surgery and do the radical nephroureterectomy.
What
Right.
does the word radical mean here?
Radical mean whole kidney, tumor, ureter with a perirenal and prerenal fat and girotas with adrenal.
Excuse me. Majority of the time, with such large tumors, you can never actually differentiate capsule from the girotas fascia. Secondly, the only 4% of Wilms tumor, including the ones of the upper pole, really involve adrenal. So now it is very clearly mentioned all over the world that adrenalectomy doesn't need to be done. Yeah. So actually, all the textbooks still talk about radical nephroureterectomy, but majority of the time, I've been all over the world. I went to 5 centers to train myself just for Wilms tumor. Ideally speaking, we really don't know whether we are doing a simple nephrectomy or we are doing a radical. So this radical word ideally should be removed from textbooks. This is my opinion. I've written articles on this. I've talked about it to the rest of the world, people about it. So there's no radical about it. Secondly, such a large tumor, which is occupying more than half of the abdomen, why would you do COG still? Why
Yes.
would you do upfront nephroureterectomy? Suppose you, now this question ideally should be to Rakesh, he's not around, but suppose you would do 50 such tumors, large ones, how many would you rupture?
Yes, sir. There is a chance of rupture, sir, in this tumor.
Then
But
why did you opt for COG and not syndrome?
sir, in our institute, with multidisciplinary team, there is a protocol that you do the upfront surgery if surgeon is comfortable and think it is operable, and if it is not involving the major vessel or
See, the question is here on ultrasound also, you've not seen the renal vein, right?
yes, yes.
And I thought on ultrasound you said there is a tumor in the renal vein. Is that what
No,
was
no,
the
no.
ultrasound?
There is no tumor thrombus in ultrasound. CT, they are saying that renal vein is not seen
So
separately.
that ultrasound was done at your center or in some other
No, at
center?
outside other
So
center.
then the obvious thing to do with the CECT is to get another ultrasound with a
Yes,
Doppler at your own center to try and
yes,
assess the thing. And I agree with Dr. Swarin. This is a very big tumor
yes,
with a high risk of rupture, and you're going to convert this child to a more, higher level with that. Why would you want to do that? You know, I
yes.
would definitely consider for pre-op chemotherapy for this child.
Yes. We usually consider very large tumor for pre-op chemo also,
So is this
but
not
for
very
this,
large?
yes,
Is this
What
not
is
very
your,
large?
no, what is your definition of very large?
when fat planes
Dimension
are
wise
not,
or volume, dimension wise or volume wise? Tell me.
no, sir, the fat plane was preserved in this case, so there
That,
was the
okay, let me teach you once for all. You know, a lot of people talk about upper pole tumors going into the liver and all that.
yes,
But trust me when I say that, in my very large experience of Wilms tumor, and I've talked to this to many people, there is always a fat plane. You can, if you are little patient with your surgery, you always get a plane between the liver and the kidney. Yeah. So if you say very large, you have to define what is very large.
yes, sir.
Is it into CC? Is it into whatever? You know, when we talk about MIS, then again there are definitions of what is very large, what
Yes,
can be operated by MIS and
7
what
cent.
cannot be operated by MIS.
Yes, yes, sir.
Yeah.
7
So what do you
centimeter.
mean by very large?
For for surgical aspect, I don't know what is very large, but for minimal invasive, there should be 10% of patient's height or 7 centimeter or tumor weighing less than 700 to 1000 ml.
Excuse me, ma'am.
So that is
Let me
adult.
clarify,
You're
let me
talking about
clarify
adult.
that too. Let me clarify that too. There is only one little case report from America which talks about this 10%. Okay. It's not a consensus all over the world. SAP has a consensus about NSS to do the initial pre-chemotherapy volume of less than 300 ml because they have proved if it is less than 300 ml, then the lymph nodes are not involved. That's the reason. You
Okay.
know, so there are definitions everywhere. You can't, it's perfectly okay with me if you say our institution policy is to operate all patients upfront, this is okay. And we accept whatever percent of rupture rates and all that. But Lakshmi has said it all. Rupture is one thing which will decide the fate of your
Stage.
child. The
Yes.
only other thing would be a histopathology
Mhm.
as
And
well as the staging. Staging and histopathology is not in your hands, but
Yes.
rupture is in your hands.
Yes, sir.
So intraoperative spill, actually, if you have to differentiate between rupture and spill, so spill is when you do it intraoperatively, rupture is it's done before you touch the patient. And that
Yes.
so intraoperative spill is one factor with the surgeon wherein you will actually mar the patient. So such a large I have stopped doing any upfront surgeries, big tumor, large tumor, small tumor, very big tumor since 2008. And trust me, my results, which used to hover around 20-25% 5-year survival, have now reached 90-95% survival. So in a country like ours, with large tumors coming, patients coming late, to switch over to SIOP from COG is a great thing. Some people do hybrid. Chota tumor hai to upfront kar do, bada tumor hai to okay, that's also acceptable. But for such large tumors, upfront surgery, I will not buy it. At least I will not buy it.
See, Priyanka, when you take your cross section of the CT, compare the size of this tumor to the opposite cross section of the opposite kidney. Right? It may be the lower pole, but you have seen CT, you've seen the kidney size on cross section on CTs. You
Yes,
look at this tumor size compared to what that kidney size would have been on cross section. Isn't it at least 20 times? Right?
Yes, 11 centimeter.
No. Volume wise, you look at that cross section. You
Yes,
look at that eyeball,
yes,
that cross section.
yes,
You're seeing the opposite side kidney.
yes.
Right. I mean, that might be the lower pole or some pole of the kidney. Even if it is a little bit bigger, that's going to be a huge tumor. So that's a huge tumor, right? Was this child operated primarily, or what happened with this kid?
Primarily operated now.
And was there any
We
problem
also had the
during
same
surgery?
discussion, should we operate or go for the upfront chemo? But we planned for upfront surgery in this patient. And
Yeah.
there was a tumor spill, but we have done the upfront
So
surgery.
that is the whole point, isn't
Yes,
it? You
yes,
should not have done that.
yes,
You've made life more difficult for the baby, right? So please don't. I mean, I don't think giving chemotherapy upfront is not that you are not a good enough surgeon. I don't think that seems to be the attitude with a lot of people, that if I opt for pre-op chemo, that means I'm not a good enough surgeon to operate on that kid, is it? No, that's not. I don't think it should be a bravado. As Dr. Sareen has pointed out, most of our patients, unless they come with a small tumor, we tend to give pre-op chemo because it makes not only the tumor smaller, sometimes the tumor doesn't move much in size, but they become more firm. It's easier to handle them without rupturing.
yes, ma'am.
Right. So I think
So
good thing that
have
all
you
of us
operated this patient?
yes, and they had a spill.
You operated this patient?
Yes, sir.
Then what happened?
Yes, sir. There was a spill, and then we converted it to stage 3.
Yeah, now another concept that has changed over the years, please remember that when we were younger, there used to be talk about local spill and generalized spill.
Yes, sir.
Now there's no differentiation. I mean, spill is a spill.
Spill is.
And a spill would mean, I mean, of course, if there's very localized spill and things like that, then we probably would still talk to our multidisciplinary teams whether to give radiotherapy or not, or whatnot.
Yes.
But a spill is a spill, and stage 3, so chemotherapy definitely just goes up.
Yes.
Then you have to just think about radiotherapy, whether we want to give radiotherapy or not radiotherapy. But spill is a spill, so don't ever do spills. Spills is the only factor that is there with the doctor's hands, which should never be done. So,
Yes, sir.
so what did you do after that? Spill happened, then what did you do?
Histopath?
Yes, ma'am, histopath was there was a triphasic tumor with epithelial predominance, and there was a complete resectional margin. Lymph nodes, we have sent 8 lymph nodes, all 7 stage was given. There was no metastasis detected in it.
Can't
And
hear you, can't hear you, can't hear
there was
you.
a complete resection was with
No,
capsular.
were the lymph nodes negative?
Yes, sir. Lymph nodes were negative, sir.
Okay.
Am I audible?
I'm coming back to Lakshmi's question to clarify very important thing here. She asked whether on CCT, whether the lymph nodes are enlarged or not enlarged, right? If suppose the lymph
Yes.
nodes are large, so what?
If lymph nodes are enlarged, then it would be disease stage 3 only. By only
Hello,
imaging, we
ma'am,
can.
that's why I asked you this question. Staging is surgico-pathological. It is
Pathological.
not to be done on imaging. You can
Yes,
keep in
yes, sir.
mind that the lymph nodes are big. What is the concept of sentinel lymph node in Wilms tumor?
Sentinel lymph nodes are the first lymph node which are drained by the tumor. They are para-aortic, suprahilar, infrahilar, paracaval, suprahilar,
It is
infrahilar.
not like that. It's not like that again. In context of Wilms tumor, the sentinel lymph nodes are supposed to be aortocaval. Yeah.
Aortic.
Yeah, so again, there's only one article which kind of clearly mentions this, although there are another two, three articles which mention about how to do lymph node staging. Yeah. So then you gave chemotherapy post-operatively
Yes, sir.
and radiotherapy.
What chemo?
As it was a stage 3, and there was no loss of heterozygosity, but they have just started it. So there was no loss of heterozygosity, and there was no pulmonary metastasis. We have given 24-week vincristine, actinomycin, doxorubicin in this case with flank radiotherapy, 10.8 gram, at another GCRI hospital of us, cancer hospital, but we refer to them, and there was chemotherapy given for 24 weeks, 3 drugs, and then radiotherapy, flank radiotherapy with boost also given.
So
And
no, the concepts of radiotherapy and chemotherapy are also very dicey, as I discussed with most of the people. When you give radiotherapy to a Wilms tumor patient, especially when you've done an intraoperative spell,
yes, in this stage, if there is a loss of
no, no,
heterozygosity,
सुन नहीं रहा बच्चे.
if there is a loss of heterozygosity, and there is if it is a favorable histology, we do not need to give radiotherapy, sir.
We're talking
Flank
about this
radiotherapy.
patient. We're talking about this patient.
There is a skill, so we give the radiotherapy, flank
When,
radiotherapy, sir.
when do we give?
Sir, from the post-op day, between the post-op day 9 to 14, within the 2 weeks.
Yeah, right. So 10th
Sorry.
is the optimal day. Now, you must all remember this for times to come. Radiotherapy suite may not be available to you, government sector, private sector, whatever sector. So when you are going to operate a patient where there may be a spill, or you never know, no, you think stage 1, it turns out to be stage 3, where you probably want to give radiotherapy. So you must inform the radiotherapy patients beforehand that I'm operating tomorrow. Please block a radiotherapy suite for us 10 days henceforth. And once
Yes,
the biopsy comes, which should come by 7th or 8th day,
sir.
you should tell them whether we will give radiotherapy or not give. He may have to
Yes.
cancel it. But if you would come to know about your diagnosis and whatnot on the 9th day and 10th day, and then you say, tomorrow you should start radiotherapy, otherwise it will be too late,
Yes.
then he may not be able to arrange it. So please do inform the radiotherapy suite before you take up the patient for surgery. And secondly, which I've noticed now in Delhi many a times, you're not supposed to stop your chemotherapy. I've seen people say, oh, give chemotherapy, this, then we'll give radiotherapy, or give radiotherapy and then we'll start chemotherapy. It
Both
is
can
not
be good.
like that in the cooperative trials. I think we already done. I want to ask you the last question before we wind up and give you marks. There has been efforts since about 1 decade that both COG and SWAP have similar protocols. And there is an effort being done in that direction. What is that?
Umbrella.
No, 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 no. बहुत जल्दी भागते हो बच्चे. What is that effort or what is that project called? Umbrella protocol was one. I'm a part of RTSG of SWAP, so I know about it. 2016, with December, we published it. And 2019 was the first recruitment ever taken. And then recruitment was very slow because COVID struck in, right? So we do not have too many patients yet under umbrella recruited. So the results which we were projecting that will come out by 2025, they're going to be now sidelined. But what is the effort that is being done so that worldwide, eventually, we will have one protocol everywhere? So to bring SIOP and COG together, a project is going on in this world now. What is that project called? It's called Harmonica. There are a lot of money which is stacked there if people want to do research on this. And lots of articles have already started coming under this project Harmonica. So good luck with you. Your presentation was above average, but not excellent. And I hope you could improve. Your problem is you shoot first and think later. Listen, absorb, then answer. And
Yes.
that is for everybody in the exam. Thank you so much. Lakshmi, if you wish to say, ask something, please go ahead.
No, Priyanka. I think you did a good job. It was a good presentation. You are sure of what you're doing. And I think if your department wants to do upfront surgery, that is not a reflection of your performance in the exam. But I think when you are talking about the how you will manage the patient, then you should be clear that what level and what are the risks of that particular management protocol. There's just one thing
Yes.
that we haven't mentioned. When you are doing surgery intraoperatively, it's a big mass, and you're probably going to need chemotherapy, radiotherapy later on. What else do you need to do? What else do you need to do at the end of that surgery after removing the kidney? What else do you need to do there? Do you know
A
the
tumor bed should be marked
with how do
titanium
you
clips. Titanium clips.
titanium? Yeah, so that's very important to do that. We should not
You are not audible,
particularly
ma'am.
to mark lateral and the inferior borders of that.
Inferior body. Yes.
Yeah, because medially they'll go up to the spine. I mean, I can
Yes,
go
yes.
on about some
Full
more questions
thickness
on
width of the
radiotherapy, but
vertebra. Yes.
yeah, so that is the problem with radiotherapy. You're subjecting the child to radiotherapy,
Yep.
which can have side effects in terms of vertebral growth.
Yes.
Radiotherapy has got also malignant potential is more.
Yes.
And you're also subjecting the patient to an adriamycin, which has also got a risk of malignancy, right? So you are giving the child a higher risk of malignancy, a second malignancy, by having a tumor spill. So
Yes,
please
ma'am.
avoid that as much as possible. Okay. I think
Yes.
overall it is a good presentation. It's a difficult topic. There's too many things to read about within Wilms. So, and of course, Professor Sareen is, top notch in that. It's very difficult to be able to answer all his questions on this particular, his favorite topic. But I think you
Yes.
did quite well. All right. Thank
Thank
you.
you. Thank you.
Thank you, sir. Thank you, ma'am. We'll stop with the case presentation now. I think a few candidates had a few questions. I'll just read out. Actually, I'll just put my question first. I just had a doubt when I was just going through the umbrella protocol. When it talks about the recommended imaging for a Wilms or a renal mass, it was written there that an MRI would be better than a contrast enhanced CT. So, but we generally do a CT only. So just wanted to clarify on that.
Evangeline, both SAOP as well as CUG now wants MRI actually.
Yeah.
So there you can do a gadolinium enhanced MRI. Most of we pediatric surgeons are more conversant with CECT and reading them rather than MRI. So we need to kind of learn MRI and switch off. So in coming times, it's going to be MRI for the abdomen and non-contrast CT scan for the chest. Standard
Okay.
all over the world.
Okay, sir. So when we talk about the
And
gold,
MRI is also better than CT at looking at veins too. MRI is pretty good at veins too.
okay, so the gold standard for imaging, like the answer that we would be expected to give would be an MRI, but we commonly perform a CT because of ease of reading for the surgeon in that way. Then
A question in the box which says that if there's tumor cell happens, radiotherapy given whole abdomen or just flank. It's a very valid question. As I said, the things have changed. It's no more considered a localized spill or a generalized slip. So if a intraoperative spill happens, then ideally speaking, it should be a whole abdomen radiotherapy. But the problem is most of the institutions, including the INIs, they cannot kind of give good coverage to the opposite good kidney. So that is why probably they have given flank radiotherapy. Flank radiotherapy otherwise would be reserved for stage 3 diseases for reasons other than spill, such as lymph nodes being positive, etc.
sir, another candidate has asked regarding the regions for lymph node biopsy.
Yeah, so as of now, there are 2 or 3 papers which are available for the template, but this is not recognized worldwide. As long as you could do a suprahilar, hilar, infrahilar lymph node biopsies along with the aortocable nodes, that's good enough. But if you would read paper from Tata Memorial, and there are some others also, they have given templates which needs to be done, but that's not globally accepted.
Sir, last question, sir. Another candidate has asked if a large mass, a renal mass, I assume, is not responding to chemotherapy, should we go ahead for a true cut biopsy?
Well, the umbrella protocol has come out with the definite indications of two-cut biopsy. I hope you all know that UKCCG, which is now UKCCLG, they used to do in UK two-cut biopsy for all patients since early 90s till about when they kind of joined hands with the umbrella protocol, and now the Europe and the UK are the same. So there are 4 different types of indications where the biopsy has to be done. When you give chemotherapy to the patient, if we're talking about the unilateral Wilms tumor, and we're talking about SAOP, then there is very clear that we are talking about 4 weeks, 2 drugs, and 6 weeks, 3 drugs for metastatic. So there is no confusion there. On the size is really not the criterion there. But when we talk about bilateral Wilms tumor, where both COG as well as SAOP would like to give preoperative chemotherapy, therein it is very important to understand what needs to be done. A couple of things. One is that do not give preoperative chemotherapy more than 12 weeks. This is true for both. Secondly, all the protocols on the both sides are a little different. But if you think that you have given say 6 weeks of chemotherapy and the tumor has not kind of shrunk at all, then there are 2 possibilities. One possibility is that this patient is having anaplastic Wilms tumors, which are not responding. But more importantly and more commonly, these are the patients which have got, the mesenchymal elements which are high. So these are patients. I mean, we talk about the epithelial, we talk about the. So if it is the myogenic element which is more, the stromal element which is more, the stromal tumors do not kind of respond. So in that case, maybe to do a biopsy to know if it is stromal, and if it is stromal, it's not going to kind of behave well with those. You can probably then stop the chemotherapy and go in for surgery. If it is anaplastic, of course, you can choose to switch over to a second line chemotherapy before you take up this patient surgery. So probably if a tumor is not responding by after 6 weeks of chemotherapy, maybe you can do a biopsy, one side, both sides. Some people believe that only one side is good enough. Others believe that the histopathology on both sides may be different. So bilaterally, those biopsies should be done. And if the tumor is not behaving, then accordingly, if it is stromal predominant, then we go ahead and do the surgeries first. But you remember that in bilateral Wilms tumor, we are talking about doing NSS both sides. So you have to be really very careful and you have to be experienced in doing NSS. If it is anaplastic on biopsies, then if a needle biopsy has picked up anaplastic tumor, then it is diffuse anaplasia. So then you have to be very, very careful whether you will be able to do NSS on both sides, whether these patients would need nephrectomies both sides and dialysis and renal transplant later. So those are very, very difficult kind of decisions to take, and they should not be done on any and every institution. These are the patients that need to be referred to specialized centers where, people cannot do this kind of surgeries. Thank you very much.
Thank you, sir. Thank you, ma'am, for spending your valuable time with us and for helping us to learn how to present and dissect such a case of a lumbar mass. Thank you, Dr. Priyanka, for your case presentation. Sir and ma'am, I've sent you the mark sheet on your WhatsApp,
Yeah,
so
done.
you can just fill that in.
I've already
Time.
submitted that. Thank you.
Okay, thank
Thank
you
you.
so much.
Good night.
Thank you so much. Good night.
Thank you, Ji.
Thank you, everyone.
Bye.